My name's Chloe Holden. I'm one of the oncology registrars training within the Wessex Deanery, and was fortunate enough to have the opportunity to do some research looking at shared decision making in the setting of cancer that can't be cured. I'm really grateful to be back here today to talk to you about my research, and have been so thankful to Barney and the PPI team, and any of yourselves who may have been present and helped support this work. So I'm just going to hopefully not talk too much this morning, but just tell you a bit about what we've done. I've come to the end of this project now and looking at taking things forward. So it's really nice to have the opportunity to feed back. So just a brief sort of introduction to this idea of shared decision making. Shared decision making is a shift away from the traditional approach whereby doctors tell patients to do things and patients go away and do them and say yes. But it involves healthcare professionals and people working together to make joint decisions about care. And it's absolutely about putting people at the centre of those decisions. It can really help people to feel empowered and listened to, happier with their care, and it can ultimately lead to better outcomes. So it's absolutely something that should be being done all of the time. It is a bit of a sea change and a shift from those very traditional approaches to medicine. But there is more guidance and more of an emphasis, particularly through the sort of NHS long-term plan, that this is really how we should be working with patients. And in the setting of a cancer that can't be cured, we know that patients face a huge number of challenges. This is more often than not a life-changing diagnosis. People are given large amounts of often really quite complicated information that they need to process. There are sometimes time pressures with needing to make decisions about care, and these decisions can be really quite difficult for people to make. And it's really important that patients' priorities and preferences are absolutely at the centre of those decisions. So what we set out to do was to learn a bit more about the challenges for shared decision making in this setting. But particularly focusing also on where it's difficult for people to be involved, where it's difficult for people to understand the information that they've been given, and think about how we can overcome some of those challenges. So there were sort of 3 phases to the project. We undertook a series of interviews with patients. We then carried out an online survey of healthcare professionals, and then held 2 expert panel meetings to sort of bring all of these findings together. So the first part then were these patient interviews, and these were being developed at the beginning of the pandemic. So much as we would have liked to have been able to do that face-to-face, we did need to do it over the telephone or video. And we wanted to speak to adults with cancer that can't be cured who'd had difficulty getting the information in a way that they could understand, or perhaps being as involved in decisions as much as they'd like. And because of this, it was really important to think about how we were offering information to the participants. So as well as a standard research participant information sheet that ran over several pages, which I did try to write nice and clearly, we also offered just a single page summary of the study, and a video of the study for those who didn't want to read the written information. And I took verbal consent rather than asking people to sign a written consent. And many thanks again to the PPI team and PPI members who helped at this point, who reviewed all of these materials, and really valuable insight that people liked the idea of a video but didn't necessarily have means of being able to watch it, which led to the idea of this video card that you can see on the right hand side, which I could send in the post to people, and they would be able to just open it up and watch a video of the summary and receive the information in that way. And that was absolutely due to having this input from PPI members at the beginning of the study to try and make sure the materials were really accessible and user-friendly. So I carried out interviews between sort of 2020 into 2021, interviewed 20 participants, which I was really pleased with, from a range of different tumour sites and treatments. Most had had recent treatment, the majority were male, and the majority were aged 51 years or over. And these participants were identified by their treating teams in their hospital as people who'd as I say, perhaps not been able to get the information they'd wanted or being involved in those decisions as much as they'd liked. And I put this table here at the bottom. I just thought this was really interesting to highlight people's different information preferences. So of those 20, only 6 just wanted the full standard participant information sheet, or PIS, sorry for the abbreviation. 2 people only chose to use the video, and then people chose a different combination depending on what suited them. And I thought that was really interesting, given how traditionally we approach recruiting people to studies. And then similarly, in terms of the type of interview, the majority were telephone interviews. That was for a variety of different reasons. But again, just highlighting that not everybody necessarily has the sort of internet capabilities to be able to access some of these online resources and systems. And I've just put up a few quotes here, and I'll read some of them out, just highlighting some of the key sort of challenges and findings from these interviews. I suspect it won't come as a huge surprise that there was a huge sort of emotional hurdle. This was a significant shock for everybody. And having had that information, it's then really difficult to take further information on board. So one participant saying, you just are caught up in it, or you just sit there and go, yes, 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 because you don't know any different and you're just absolutely overwhelmed. There was a feeling very much that people were in the expert's hands and that there wasn't really a decision to be made, that the expert wouldn't be recommending it if they didn't think it would do me any good, or perhaps not seeing an alternative to pursuing an active anti-cancer approach. Some described that the information that they were given wasn't really accessible to them. One explaining that he felt that the information was written for another healthcare professional and it was complete gibberish, and therefore, you know, very much relied on what they were told verbally instead of any other additional resources. There was also a feeling that people didn't want to be a burden or a bother, being hesitant to phone up and contact the CNSs or contact the hotline number because of worrying about wasting people's time, despite the fact that those issues might be really important to them. And then the bottom just was interesting for me as a healthcare professional, but sort of one person particularly describing, and many actually looking back on the treatment and feeling it wasn't that bad, despite also describing significant side effects from treatment, and this participant in particular being admitted with a life-threatening side effect of their chemotherapy, but actually in retrospect feeling that the experience wasn't that bad. So after those interviews, we wanted to hear from the perspective of the healthcare professionals on the other side of this partnership, and undertook an anonymous online survey of healthcare professionals caring for patients with incurable cancer in the NHS. And this link was shared through several of the professional bodies, including the Association of Cancer Physicians, the UK Oncology Nursing Society, and the sort of newly developed board of the Association of Supportive Care in Cancer, and shared by word of mouth as well. We were really pleased to get 70 responses to this, primarily from doctors and primarily from medical oncology doctors who particularly specialise in giving chemotherapy and immunotherapy treatments that travel around the bloodstream. But we also had input from palliative care teams and the specialist nurses, as well as some clinical oncology doctors as well, and a good proportion of nurses and a pharmacist as well. So a really nice spread of different professionals involved in supporting patients with decision making in this setting. So we asked them, how often do you use shared decision making in certain situations? And it's a bit of a busy graph here, so please forgive me, but really sort of demonstrating the ones at the top here are where healthcare professionals particularly tended to use shared decision making, so usually or always, and then coming down to the bottom where they perhaps might use it less commonly. And those decisions sort of, oh, let's go back there. So when thinking about treatment and discussing symptom management and the need for further investigations, people felt that they did tend to use shared decision making in those situations. And then perhaps where there were some decisions where people needed to follow sort of closer guidelines, they might use it less so, such as when thinking about schedules for follow-up, when adjusting treatment doses, so where there might be a safety element. And also when discussing cardiopulmonary resuscitation. So just interesting differences there. We then also wanted to find out about what might make healthcare professionals a bit more reluctant to use shared decision making. And the top reason that came out was this feeling that there was a lack of time, and the idea that the shared decision-making process was more lengthy, that people needed to impart their knowledge and their expertise about the cancer and the cancer treatments, and not feeling that there was time to enter into these longer conversations. Also, when patients were perhaps too unwell, either physically or emotionally. But quite high up there was the feeling when patients had requested that people make a decision on their behalf. And I think it would have been interested to drill into that a little bit more and see whether that could be explored a bit further. There were also a significant proportion of people who felt that there weren't enough resources to support these conversations, and various other reasons given for why people might be reluctant to use shared decision making. And then there were just a few more quotes from the written text that people gave in response to the survey. The feeling that shared decision making is not always appropriate. So, as mentioned, if people were too distressed, that they might not be able to participate in that process. Where there is not enough time in a clinic appointment. So time can limit how long I explore a patient's preferences and what is important to them, but I will encourage them to go away and think about it and come back. And then this sort of assumption of not wanting to follow a formulaic process, but using their communication skills and their training to sort of work through that process. But, feeling that it's normally implied and obvious that patients can take part in these decision-making conversations. Whereas from speaking to the patients, that wasn't necessarily how patients felt about their experiences. So with all of these findings, we then held two panel meetings, one involving healthcare professionals, so with a number of senior nurses and cancer doctors, as well as some support workers, and then one with patients and carers. And again, thanks to Barney and the team and to all of those who participated in that panel meeting. That was really interesting. And a great opportunity to sort of discuss all of these findings and kind of identify what the key challenges were. And we came up with sort of there were a number of key topics that came up. One of them being this need to try and shift that focus away from the traditional approach to medicine, that actually patients, we're talking about patients, they are individuals, they're allowed to make their own choices and should be encouraged and facilitated to do so. But we need to try and shift that way away from the doctor knowing best, but actually the patient knows the best about themselves. The importance of good communication skills and making sure there's a really balanced discussion of the options. The absolute importance of team working and making sure that people are well supported. As I've talked about, this is a huge challenge. The diagnosis can come as a huge shock, and people need to be really well supported to be able to come to terms and work out what's right for them. We also talked about some of the logistical challenges and that the system itself is really inflexible. You might just be sent an appointment and have no say over when that might be. The time slots are often quite short and limited. There were challenges, particularly during COVID, about whether appointments were face-to-face or virtual, and that brought challenges as well. And also coming back again to the resources to support shared decision making, we often have available standard written information that's quite lengthy and text based, and there aren't a huge number of other resources that are often used and easily accessible in the clinic or for people to refer to help that decision making process. So much as I would have loved to come out of this project thinking, well, there's this one simple thing I need to do and I'm going to solve this problem and make shared decision making much easier in this context, actually there are lots of different things that we need to try and address. And if we can try and pick some of those, we might be able to lead to some positive change. So just thinking a bit about what I think the sort of main issues are and how we can think about trying to make things better. The first is that the system isn't perfect. There are lots of practical issues. So can we make things easier? Can we make sure that the paperwork is really simple, that there's not lots of jargon, that it's perhaps less automated, or making better use of appointment and clinic letters, offering more flexibility where possible to suit the individual. but also trying to draw on a wider pool of resources that are easy to understand, that are accessible, that are available in the clinic for people to use when a standard written information might not be suitable. How can we encourage people to feel that they have the power to speak up and ask questions? And are there some aids that we could use to try and allow people to compare the options a bit more easily, and take that home and share and talk about with their family and their loved ones? The second challenge relates to this issue of the huge shock of the diagnosis, and how can we help support people with the emotional challenges that a diagnosis brings. So thinking about making sure that people are encouraged to bring family and friends and advocates to appointments, and that's expected, not a sort of added nicety. That there's really important that we have really good access to CNSs and support workers. The fundamental role of the clinical nurse specialist was absolutely highlighted throughout this, but also closer working with other teams, the GP, the palliative care teams, and making sure that from the very beginning there's really early signposting to other support services. So several described that soon after their diagnosis they didn't know where to turn to try and get help, but can we try and make that easier from the beginning so that people know that there's support right from the start, to try and help them begin to come to terms with the information they've been given. And then finally, addressing these sort of traditional reviews of doctor and patient roles. So working as we always are on trying to develop better communication skills for healthcare professionals and training, and providing them with resources and strategies and techniques to be able to facilitate these conversations. We know from research that actually these conversations don't take a huge amount of time, longer than standard. So how can we embed this more into what is standard practice? And then sort of on a much wider scale, there's need to try and change mindsets. And I think things are shifting, but moving away from that traditional view of seeing the doctor and doing what the doctor says, but really working together and trying to formulate a plan that best suits the individual. So I have had the opportunity to sort of take all of this forwards. I'm pleased to say I've come to the end of my PhD and had a really valuable process of learning how we can try and carry this forwards. I've been able to present these findings at the European Society for Medical Oncology conference, and with a poster and a presentation recently at the UK Oncology Nursing Society conference. I've been presenting the findings locally, and we're working on a publication to share these findings in the academic world. And I've also been having some meetings with decision makers at both the hospital level and the Wessex Cancer Alliance level, to try and explore how we can take some of this learning and begin to embed this in clinical practice, and try and begin to facilitate that shift going forwards. So I owe a huge thank you to many people, to the PPI team, to Barney, and to all of you for coming today, but also to those who've participated throughout, to the patients and carers who've been involved throughout the study, the hospital and research staff, the healthcare professionals who've supported me throughout, professional bodies for sharing the survey, and the Robert White Legacy Fund, and of course my supervisors, without whom this project wouldn't have been possible. So a bit of a whistle-stop tour, but thank you again all very much for coming and for listening. And I'd love to take any questions or comments, and if there was anything that you wanted to ask me about or get in touch about at future point, then please do.